Welcome back to the deep dive. Today we are stripping away the high-tech veneer of modern medicine.
We are. We usually talk about AI in healthcare or, robotic surgery,
Sure.
CRISPR gene editing.
All the futuristic stuff. But today we're going way back to basics. We are putting on the white coat, walking onto the ward, and standing right at the bedside.
It's back to the roots. We're looking at the detective work that happens long before a scalpel is ever even listed.
Exactly. We're diving into a book that is, well, technically it's a textbook, but it reads like a field manual for a very specific kind of investigation.
I know the one. Bedside Clinics and Surgery.
That's the one. Second edition by Dr. ML Saha. And I mean, you look at the cover and you think this is just for, stressed out medical students cramming for their final practicals.
And it is that. It is absolutely that. Make no mistake.
But then you start reading it and you realize it's actually a guide on how to read a human being. It's all about becoming a medical detective.
Right.
Because here's the hook. The thing that really grabbed me. Surgery isn't just about what happens in the operating theater. The decision to cut, or crucially, not to cut, is often made based on a conversation.
A handshake.
And a quick glance at someone's fingernails.
That is the long case. In the medical world, and especially in surgical training, the long case is the ultimate test.
Right.
You're dropped into a room with a patient you have never met. You don't have CT scans yet, no blood work in your hand. You have your eyes, your ears, your hands, and your brain.
And that's it.
That's it. And from that, you have to come up with a diagnosis that could save or, lose a life.
The stakes are they're incredibly high. So the mission for this deep dive is to deconstruct that whole process. We want to decode this rigorous, almost military-grade method that surgeons use to evaluate a patient.
It's a system, a very strict system.
And we want you, the listener, to walk away with the ability to look at a body and see what a doctor sees, from spotting clubbed fingers to really understanding what a moon face actually means.
It's all about noticing the details that everyone else just ignores.
So let's unpack this. The book divides the whole process into these very stripped segments, and it starts with segment 1, the interrogation.
Or, as the polite medical term goes, history-taking.
But interrogation is actually a pretty good word for it, isn't it?
It really is.
Yeah.
Because this is not a chat. It is a data extraction mission.
So the book starts with what it calls the particulars. Name, age, sex, religion, occupation, address. And to me, this just felt like, filling out a standard admin form at the dentist.
Right. The boring stuff.
But Dr. Saha implies this is actually the first step of the diagnosis.
Is the demographic filter.
Yeah.
You're already narrowing down the suspect list of diseases before the patient has said a word about their symptoms.
How so?
Well, take age, for instance. If you have a patient who is, say, 18 years old, and they're complaining of bone pain, you are thinking about entirely different pathologies. Maybe something like osteosarcoma.
Yeah.
Than if you have an 80-year-old with the exact same pain. In that case, you might suspect metastasis from another cancer, or just degeneration.
And occupation isn't just small talk to build rapport.
Oh, absolutely not. Occupation is all about environmental exposure. If someone works in a dye factory, their risk for bladder cancer just skyrockets.
I see.
If they're a farmer, you might look for things like hydatid cysts from animal contact. Every single answer rules 1,000 diseases in or out.
There was a detail here that I found, hilarious, but also deeply stressful. The book explicitly tells students to write down the bed number.
Yes.
Not just the patient's name, but the specific bed number in the exam hall.
That is the voice of pure experience speaking to the terrified student. I mean, you have to imagine the scene. It's the final exam.
Right.
The hall is chaotic. There are 50 patients. Examiners are shouting.
Yeah.
If you step away to present your case and you forget which bed your patient was in,
Oh, no.
It's game over. You literally can't diagnose a patient you can't find. It's about precision from second one.
Okay, so we've got the admin data. Now we get to the core of the interview. The chief complaint. I always just assumed this was asking, so what hurts?
If only it were that simple. The chief complaint is where the student usually hangs themselves. Dr. Saha lays out some very strict rules here.
And the first one is chronological order.
Chronological order, yes.
Meaning you can't just lead with the symptom that's bothering you the most today?
No. You have to tell the story of the disease as it unfolded in time. If a patient comes in vomiting blood today, but they've had a, gnawing stomach pain for 3 years, the pain is listed first.
Why?
Because you're building a timeline. The disease has a narrative arc, and you have to respect it. Yeah. The first symptom is often the biggest clue to the origin.
And then there's the one symptom rule. This is where I really started to realize how precise medical language has to be. The text says, do not combine symptoms.
This is a classic trap. A student might write, pain and jaundice for 2 years.
That sounds efficient. It sounds like normal English.
It does. But it's medically sloppy. It implies that the pain and the yellow skin start at the exact same second and have behaved in exactly the same way for 2 years.
Which almost never happens.
It never happens. The book insists you separate them. Pain for 2 years. New line. Yellowish discoloration for 2 months.
I get it. So by splitting them up, you're forcing yourself to analyze each one as a separate piece of evidence.
Exactly. You are isolating the variables before you even begin.
And brevity, he says, limit it to 3 or 4 symptoms. But what if the patient is what you'd call a complainer? You know, what if they have a headache and a toe ache and their back hurts and they feel dizzy?
The surgeon's job is to filter the signal from the noise. If you write down a laundry list of 20 complaints, you aren't diagnosing, you're just transcribing.
Right.
You have to identify the 3 or 4 things that actually brought them through the hospital doors.
Yeah.
It forces you to prioritize.
So once we have the headlines, the chief complaint, we move to the history of present illness, or HPI. This is the deep dive into the narrative.
The story.
And there's a phrase here that I absolutely love. The book warns, never say the patient was perfectly well before the illness. You must say they were apparently well.
Apparently well. It's a liability shield and a philosophical stance all in one.
It sounds like something a lawyer would come up with.
It is precise.
Yeah.
Perfectly well is an absolute. Nobody is perfectly well. There could be cancer cells dividing, arteries hardening, stones forming, all completely silent.
Okay.
Apparently well acknowledges that as far as the patient knew, they were fine. It admits the limitation of our own knowledge.
That's a great distinction. Now, in the HPI, the book says we have to elaborate on every single symptom. And this is where we get into the system-specific inquiries.
Right.
This part of the outline was fascinating because it really shows how different body systems have their own unique language of distress.
They do. You don't ask the same questions for a stomachache as you do for a cough.
So let's look at gastrointestinal, or GI. The book mentions asking about a rolling mass. That is such a visceral image. What on earth is a rolling mass?
It is exactly what it sounds like.
Okay.
Imagine a large tumor or a blockage in the intestine. The gut is trying to push food past it, so the muscles contract really hard. That's called peristalsis.
Okay.
And the patient can actually feel and sometimes even see a ball moving under their skin. It appears, it rolls across their abdomen, and then it disappears.
That is terrifying.
Kind of rolling sensation, a clear sign of obstruction.
And then you have to ask about bowel habits, but not just, are you regular? The book gets pretty graphic. It lists the word melena.
Melena is a critical sign, and it's not just bloody stool. It refers specifically to black, tarry, and very foul-smelling stool.
Why black?
Because the blood has been digested. It means the bleeding is happening high up in the GI tract, in the stomach or the esophagus, for example.
Right.
By the time that blood travels all the way through the intestines, the stomach acid and the digestive enzymes have turned it black and sticky. If you see bright red blood, the bleed is much lower down.
So the color tells you the location.
Instantly, melena tells you where to start looking.
Okay, let's switch to urinary.
Here you're looking for the mechanics of urination. Hesitancy. Does the patient have to, stand there and wait for the flow to start?
What does that suggest?
An obstruction. Maybe an enlarged prostate in an older man. And then you ask about urgency. Do they get a sudden urge and have to run to the toilet? That's more about irritation, maybe an infection.
And cardiorespiratory. The book lists pink frothy sputum. That sounds incredibly specific. Not green, not yellow, pink, and frothy.
That is the hallmark of acute left ventricular failure. It's a medical emergency.
What's happening in the body?
Basically, the heart is failing to pump blood out to the body, so fluid backs up into the lungs. The patient is, for all intents and purposes, drowning in their own fluids.
And the pink froth.
The air they're desperately breathing in mixes with this fluid and a tiny bit of leaked blood from the capillaries, and it whips it into a pink foam.
So if you hear pink froth, you aren't thinking infection, you're thinking heart failure.
Immediately. It's a code blue situation.
And finally, neuro. The outline mentions wasting of the tongue. I didn't even know a tongue could waste away.
It's a muscle like any other. If the nerve supply, in this case the hypoglossal nerve, is cut or compressed by a tumor, the muscle fibers die off.
So what does it look like?
The tongue gets shriveled and wrinkled. but usually just on one side. So asking the patient to stick out their tongue isn't just rude.
It's a neurological exam.
It's a cranial nerve exam right there.
It's incredible how the body broadcasts these signals if you just know how to tune in. But then Dr. Saha throws a curveball. He talks about the negative history.
This is one of the most sophisticated concepts in the entire book.
It sounds so counterintuitive. Why would you list what isn't happening?
Because novices look for what is there. Experts look for what isn't there to rule out the big threats.
Okay.
The book explicitly forbids a student from writing family history, nothing significant. That is considered lazy and unacceptable.
So what should you write instead?
You have to prove that you checked for the specific hereditary killers that are relevant to the case. If a patient has rectal bleeding, you must write, no family history of polyposis coli.
Right.
If it's a breast lump, you write, no family history of breast cancer in mother or sisters. You are showing your work, you are proving you considered the genetic angle and actively ruled it out.
It's a kind of defensive documentation. I asked the question, Judge, I promise.
Exactly right.
Now, there's a nuance in the personal history section that I think everyone listening should hear because we misuse these words constantly. The difference between addiction and habit.
Oh, this is a big one.
I mean, I say I'm addicted to coffee all the time, or I have a habit of checking my phone, but Dr. Saha draws a very, very hard line here.
He does. And for a surgeon, that distinction can be life or death. In this text, addiction is defined very strictly. It implies physical and mental dependence, where withdrawal symptoms will occur if you stop.
So we're talking about shaking, hallucinations, physical illness.
Yes. The DTs, for example.
Yeah.
If you don't get the shakes when you stop, it's just a habit.
So if a guy smokes 2 packs a day for 40 years, but he claims he can stop for a week without physically crashing?
Then for the purposes of this exam, you write smoker, habit. You do not write addict.
That feels weirdly pedantic. Why does it matter so much?
It matters for post-op care. An addict, say, to alcohol, might go into delirium tremens on the 3rd day after surgery because they aren't drinking on the ward. That can kill them. You need to anticipate that and medicate them to prevent it. A habit smoker just needs a nicotine patch and some willpower. The label dictates the entire post-operative treatment plan.
That makes total sense now. And for female patients, the history taking seems to double in length. Menstrual, obstetrical, menarche.
Because hormones are the silent architects of so many surgical diseases. Breast cancer, thyroid issues, gallstones, they're all modulated by estrogen and progesterone.
Okay.
Knowing if a woman is premenopausal or postmenopausal completely changes the statistical probability of a lump being cancer versus the benign cyst. You cannot skip those questions.
So we've grilled the patient, we've got this massive dossier of verbal evidence, and now we switch modes. We stop talking and we start looking.
Sherlock Holmes mode.
Segment 2, the general survey. The book calls this the first look. This is before you even touch the painful area. You're just scanning the chassis.
That's a good way to put it.
And the very first thing you do is try to put a number on their vitality, the performance status.
This is crucial for decision-making. The book mentions 2 scales, the ECOG scale and the Karnofsky scale.
I've never heard of these. How do they work?
Think of it as a fitness for surgery score. ECOG is simple. It's 0 to 4. 0 is you or me, fully active, no restrictions.
And 4.
4 is completely disabled, confined to a bed or a chair, unable to perform any self-care.
And Karnofsky.
It's a more granular 0 to 100 scale. 100 is normal, 10 is normal, moribund. Fatal processes are progressing rapidly. 0 is dead.
I assume this isn't just about labeling the patient. This sounds like a risk assessment tool. You're trying to figure out if the surgery is going to kill them faster than the disease, right?
That is exactly it. It is the gonna-go gauge for the operating theater. If a patient is ECOG 3 or 4, they might not survive the anesthesia, let alone the recovery.
So you change the plan.
You might choose a smaller palliative procedure instead of the big curative resection. The number dictates the entire strategy.
And then we get to faces. Reading the face, this felt very Victorian, like physiognomy, but it's real medical science. The face tells the story of the endocrine system.
Oh, the face is a billboard. It cannot hide hormonal imbalances.
So let's talk about thyrotoxicosis. That's the thyroid issue. The book describes a stare.
It's a look of permanent, frozen terror. Because of the excess thyroid hormone, the muscles and fat behind the eyes swell up and push the eyeball forward.
That's exophthalmos.
Exophthalmos. Right. You can see the white of the eye, the sclera, all the way around the iris. They look perpetually startled.
And then there's moon face. That's a specific medical term.
A very specific term for Cushing's syndrome. Excess cortisol. The body redistributes fat to the face and the back of the neck.
So the face just puffs up.
It becomes perfectly round, red, and puffy, and it's often accompanied by hirsutism, excess facial hair, and acne. You see that face walk in the door, and you know their cortisol levels are sky high before you even say hello.
What about acromegaly?
The giant. This is what happens when you have excess growth hormone as an adult, after your bones have fused.
So you don't get taller.
You get thicker. The bones get thicker. The forehead becomes heavy and prominent. The nose enlarges. The lips get thick. The hands become spade-like. It's a coarsening of all the features.
And then there was one that actually gave me chills reading it, the Hippocratic facies.
This is the oldest description in medicine. It comes directly from Hippocrates himself. It is the face of impending death.
How does the book describe it?
Sunken eyes, a sharp nose, hollow temples, the ears are cold and retracted, and the skin is leaden or pale.
And what does it mean?
It's what you see in severe end-stage dehydration or peritonitis. It's the look of the body shutting down its peripheral system to try and keep the core alive for just a few more minutes.
It's haunting that there's a standard definition for the look of death.
It is.
Huh.
But recognizing it tells the surgeon, stop asking questions and start resuscitating. Now, there's no time to lose.
Let's move to something slightly more active. Decubitus. This is just a fancy word for how the patient is lying in bed.
Body language in bed, exactly.
The book contrasts two patients, one with peritonitis and one with colic.
This is a classic exam question. So
Yes.
peritonitis is inflammation of the lining of the entire abdominal cavity. It is excruciatingly painful.
Okay.
Every time you move, even breathe, the inflamed surfaces rub against each other. So how does that patient lie?
Completely frozen.
Absolutely still. They are terrified to move a single muscle. They breathe shallowly to avoid moving their diaphragm. They lie like a statue.
And the patient with colic, like a kidney stone, for example.
Colic is a spasm of a hollow tube, like an intestine or a ureter. The pain comes in waves. That patient is the complete opposite. They're rolling around, they're thrashing.
They can't get comfortable.
They cannot find a comfortable position. They're pressing a pillow into their stomach, they're on their knees, they're restless.
So just by standing at the door and watching if they are frozen or thrashing, you can differentiate between a burst appendix and a kidney stone.
Before you even say hello, that is the power of pure observation.
Moving on to segment 3, vital clues. Hydration, nutrition, and color.
The basics of life support. The fundamentals.
Hydration first. We all know we should drink water, but how does a surgeon check it without a blood test? The book talks about the pinch test.
Skin turgor. You pinch a fold of skin, usually on the forearm or the abdomen, and you let it go.
And what are you looking for?
In a healthy, hydrated person, it snaps back instantly. It's elastic. In a dehydrated patient, it tense. It stays standing up for a second or two before it slowly sinks back down.
Like old dough.
Exactly. And the tongue is another key sign. A dry, parched tongue is a late sign. If the tongue is dry, the tank is well and truly empty.
Then nutrition. We use BMI, body mass index, all the time, but the book suggests BMI isn't enough for a surgeon.
BMI is a very crude tool. A bodybuilder has an obese BMI because muscle is heavy. A patient with a massive tumor and, say, a belly full of fluid might have a normal BMI, even though their arms look like sticks.
So it's misleading. What do you measure instead?
You get out the tape measure and the calipers. You measure skin fold thickness over the triceps to check the subcutaneous fat stores.
And you measure the arm.
Mid-upper arm circumference measures the muscle bulk. These two measurements tell you if the body is cannibalizing its own muscle and fat to survive, which happens in advanced cancer or chronic infection.
And glossitis? This is looking at the tongue again, but for vitamin deficiency.
Specifically B vitamins. A healthy tongue is rough. It has papillae, those little bumps. In glossitis, the tongue becomes red, raw, and completely smooth.
What does it look like?
It looks like a piece of raw steak, and that's a huge red flag for severe malnutrition.
Now let's talk color. The color palette of disease. Anemia, jaundice, cyanosis.
This is Visual Diagnostics 101. Absolutely fundamental.
For anemia, a lack of red blood cells, we look for pallor. The book lists some very specific spots, the lower palpebral conjunctiva.
Right. You gently pull down the lower eyelid. The inner surface should be a nice, healthy pink. If it's pale or almost white, that's a sure sign of anemia.
And you check other places too.
You also check the nail beds and the tip and dorsum of the tongue.
Okay, jaundice. Yellowing. The book warns about latent versus clinical jaundice. What's the difference?
Right. Clinical jaundice is when you can see it from across the room. The person has bright yellow skin. That happens when the bilirubin levels in the blood are over 2 milligrams per deciliter.
But latent jaundice is the danger zone.
That's the danger zone. It's between 1 and 2 mg%. The skin looks totally normal to the casual observer.
So where do you find the hidden yellow?
The book gives us 2 secret hiding spots. First, the upper bulbar sclera. You ask the patient to look down at their feet, and you gently lift their upper eyelid.
Why there? Why the upper part of the eye?
Because the lower part of the eye is exposed to sunlight, wind, and dust, which can cause some discoloration over time. The upper part is protected by the eyelid. It's pristine white.
So any yellow will show up there first?
It will show it there first. It's the most sensitive spot.
And the second spot?
Under the tongue. You ask the patient to touch the roof of their mouth with their tongue. The mucous membrane there is thin and highly vascular. It glows yellow very early.
Fascinating. And finally, cyanosis, turning blue.
Which means a lack of oxygen. But here, the clinician must distinguish between central and peripheral.
What's the difference?
Peripheral cyanosis is bleed fingers or toes. That might just mean you're cold or you have sluggish circulation, like in Raynaud's disease. It's not necessarily an emergency.
And central?
Central cyanosis is when the tongue and the inner lining of the lips turn blue. That means the core blood supply, the arterial blood coming directly from the heart and lungs, is not carrying enough oxygen.
So that's a disaster.
That is a heart or lung disaster in progress.
So blue fingers, maybe put on some gloves. Blue tongue, call the ambulance.
Effectively, yes. That's a good way to think about it.
This brings us to segment 4, hands and feet. I never realized how much a hand could tell you until I read this section on clubbing.
The nail mystery.
Yeah. What is clubbing exactly? It sounds like a nightlife activity, but in surgery, it seems to involve fingers looking like drumsticks.
It's a very specific deformity of the fingernails and toenails. It's strongly associated with chronic lung diseases, like lung cancer or abscesses, or some types of congenital heart disease.
And what's actually happening to the finger?
The soft tissues at the base of the nail swell up. The nail itself gets excessively curvy, both side to side and front to back, sort of like a parrot's beak.
And the book gives us geometry to test it, the Lovey-Bond angle.
Medical geometry, that's right. Normally, if you look at your finger from the side, the nail comes out of the skin at a slight dip, an angle of about 160 degrees.
Okay.
In clubbing, that dip fills in with the swollen tissue. The angle becomes flat, so 180 degrees, or even bulges out to greater than 180 degrees.
And there's this magic trick called Shamroth's sign.
The diamond gap. This is a great one. And you at home can do this right now. Put your hands up. Now put the fingernails of your 2 index fingers together, back to back.
Knuckle to knuckle.
Exactly. Press them together. Now look at the space right between the nail beds at the base of your nails. You should see a tiny diamond-shaped window of light coming through.
I see it. It's small, but it's definitely there.
That's normal. If you have clubbing, that window disappears completely. The swollen bases of the nails touch each other. No diamond means clubbing.
That is wild. It's such a simple binary test.
And it can tell you about the condition of the lungs without ever needing a stethoscope.
And looking at the feet, we check for edema, swelling. But gravity plays a massive role here, doesn't it?
Gravity dictates where the excess fluid goes. If a patient is walking around or ambulant, the fluid sinks to the lowest point, the ankles.
So you press on the shin bone.
On the medial tibia, just above the ankle bone. That's where you check.
But if they are bedridden?
If they're lying down, the ankles are at the same level as the heart. So the fluid pools in the new lowest point, the lower back, over the sacrum.
So if you just check the ankles of a bedridden patient, you might think they're fine while their entire back is full of fluid.
Exactly. You have to remember to roll them over. You have to hunt for the edema.
And the pitting part, what does that mean?
It means you press your thumb firmly into the swollen area for about 5 to 10 seconds. When you take it away, if it leaves a pit, a dimple that stays there for a few seconds, like you pressed into raw pizza dough, that is pitting edema.
And that means?
It means there is excess water in the interstitial spaces between the cells.
Segment 5, we are moving up to the neck and the vitals. The neck seems to be a very, very busy highway in surgery.
It is the superhighway between the head and the body. Absolutely. And the traffic report comes from the JVP, the jugular venous pressure.
The book calls it the barometer of the right side of the heart.
That's a perfect analogy.
Yeah.
Think of the internal jugular vein in your neck as a column of blood that goes straight down into the right atrium of the heart. There are no valves in the way to block the signal.
So we are literally watching the heart's pressure through the skin of the neck.
That's what you're doing. You prop the patient up at 45 degrees.
Yeah.
You look at the side of their neck. And you aren't looking for the big, thumping carotid artery. You're looking for a subtle, double flicker wave just under the skin.
The JVP.
That's the JVP. And if that wave is climbing high up the neck, more than 2 centimeters vertically above the angle of the sternum, it means the right side of the heart is full. It's failing. Back pressure is building up.
It's a pressure gauge built right into our anatomy.
Precisely.
And then there are the lymph nodes. The book gives us a whole geography lesson here, levels I through 6.
This is crucial for cancer surgery. You absolutely have to know the map of the neck. But the most interesting one for our purposes is level V, specifically the supraclavicular nodes.
And the book highlights one specific node, Virchow's node.
The Trojan horse. It's a lymph node located in the left supraclavicular fossa, that little hollow right above your left collarbone.
Why is this one tiny spot so special?
You have to think of the lymphatic system as the body's sewage system. Now, the thoracic duct is this massive lymphatic highway that carries fluid from your feet, your gut, your stomach, basically everything below the diaphragm. And it travels up the left side of the spine.
Okay.
And it dumps into the venous system right behind your left collarbone.
So the left collarbone is basically the main drain for the entire lower body.
It's the final exit point. That's why Virchow called it the signal node. A tumor in the stomach sheds cancer cells into that lymphatic river. They float all the way upstream, and they get stuck in the first filter they hit that lymph node.
So you feel a lump in the neck, but the enemy is actually hiding in the belly.
You can diagnose stomach cancer or testicular cancer or esophageal cancer just by shaking the patient's hand and palpating their neck. That is the power of anatomy.
The book also details how to feel for them. It says you have to stand behind the patient.
Always. If you stand in front, you're pushing the nodes away into the neck muscles. When you stand behind them, you can flex their neck slightly to relax the tension, and you can gently trap the nodes against the muscles with the pulps of your fingers.
It's a tactile art.
It really is.
Let's check the pulse. We all know how to find a pulse, but the book mentions rolling the artery. What does that mean?
This is a test for atherosclerosis, or hardening of the arteries. You find the radial artery at the wrist, and you use one finger to empty the blood out of a small section of it, and then you try to roll the empty tube against the bone with your other fingers.
What should it feel like?
It should be soft, almost imperceptible. If it feels like a stiff cord or a piece of uncooked macaroni, that means the vessel wall is thickened with plaque. You know their vascular age is much older than their biological age.
And then there's the connection between fever and pulse. Relative bradycardia.
Right. Normally, for every degree of fever, your temperature goes up. Your heart rate should increase by about 10 beats per minute. The engine revs up to fight the infection.
Makes sense.
But in certain diseases, most classically typhoid fever, a strange thing happens. The temperature goes way up, but the pulse stays slow. It doesn't rise to match.
The engine doesn't rev.
Exactly. That dissociation, that gap between a high fever and a slow pulse, is a huge neon sign pointing directly to typhoid.
Finally, respiration and temperature. The book describes Cheyne-Stokes breathing. The description of this was eerie.
It is terrifying to watch in person. It's the hyperpnea-apnea cycle.
Describe the rhythm for us.
The patient starts breathing, and their breaths get deeper and deeper, faster and faster, almost gasping. And then they slow down.
Yeah.
And then complete silence. Apnea. They stop breathing entirely.
For how long?
It can be 10, 20, sometimes 30 seconds. The room goes completely quiet. You think they're gone. And then it gasp. And they start the whole cycle all over again.
What causes that?
It's a sign of a brain that is losing central control. You see it in severe intracranial pressure or end-stage renal failure. The brain's chemical sensors are lagging. It breathes too much, washes out all the CO2, stops breathing to build it back up, overshoots, and starts again.
And it often signals.
It often signals that the end is near.
And lastly, fever patterns. I honestly thought fever was just, you're hot. But the book breaks down. Continuous, remittent, intermittent.
This comes in the days before we had antibiotics, when doctors could only watch fevers run their course. Continuous means it stays high, like a plateau typical of pneumonia.
Okay.
Remittent means it zigzags up and down by more than 2 degrees Fahrenheit, but it never touches normal. You see that in TB or sepsis.
And intermittent touch is normal.
Yes, it spikes and then drops all the way back to normal at least once a day. And the names tell you the timing. Quotidian is a daily spike. Tertian is every alternate day. Quartan is every 3 days.
And those specific timings map to specific diseases.
Malaria. The malaria parasite has a life cycle where it bursts out of red blood cells every 48 or 72 hours. The fever spike corresponds exactly to millions of parasites exploding into the bloodstream. You can diagnose the strain of malaria just by looking at the fever chart.
It really highlights how observation was the primary lab test. They didn't have PCR. They had a thermometer and a clock.
And patience. A lot of patience.
So we've gone through the interrogation, the general survey, the hands, the neck, the vitals. We finally reached the outro, the provisional diagnosis.
This is the moment of truth.
The book says it's not a guess, it's a statement.
That's right. You don't say, well, I think it might be. You don't say, it could be X or Y. You are trained to say, this is a case of carcinoma of the left breast, T2N1M0.
Wow.
You synthesize all those clues, the history, the apparently, well, caveat, the hard lump you felt, the lymph node in the armpit, the lack of bone pain, into a single definitive conclusion.
It's empowering. You aren't just looking at symptoms anymore. You are naming the enemy.
That is the transition from student to doctor, the ability to commit to a diagnosis. Because once you commit, you can finally treat.
Summing all this up, Bedside Clinics in Surgery is just this incredible reminder that the human body is constantly broadcasting data. It's screaming information at us if we just know how to listen.
It really is. The hydration of the tongue, the angle of the nail, the rhythm of the breath, the hidden yellow in the corner of the eye.
The mission of this deep dive was to show that surgery really starts right at the bedside.
And I'd argue that even with all our amazing technology, CT scans, MRIs, genetic testing, nothing replaces the hands and eyes of a skilled clinician. A CT scan can miss a small lump that a trained finger can feel.
And a blood test can't tell you the difference between a patient rolling around in agony versus one lying deathly still.
Exactly. It connects you to the patient.
Right.
It makes the patient a person, not just a file or an image on a screen.
It does.
And here's a thought to leave you with. We talked about Virchow's node, how a little lump in the neck can signal a massive cancer in the stomach. It just makes you wonder, how many other signals is your body sending right now? How many other Trojan horses are there that we just haven't learned to decode yet?
That is a provocative thought. Maybe we're still just scratching the surface of what the long case can actually tell us.
I think we are. The body is the ultimate text. We just need to keep learning how to read it.
Thank you for joining us on this medical detective journey. Next time you look at your fingernails, maybe check for that diamond gap.
And stay apparently well.
We'll see you in the next deep dive.